I think I'll just get started. I just have a few slides. I think in order to honor the named lectures, I just wanted to give a brief history of who they are named after. And so I just wanted to give a very brief history on, this is the Edgar J. Poth lecture. And Dr. Poth was a surgeon in Galveston, Texas. He trained at the University of Texas, got a BA and master's degree by 1923, went to the University of California and got a chemistry PhD in physical chemistry. He then became an instructor at Johns Hopkins University in pharmacology, and while he was teaching pharmacology, got his medical degree by 1931. He did his postgraduate training, or the equivalent of a residency, for the 1930s in Stanford, and then he stayed on faculty at Stanford and had other faculty appointments back at Hopkins and at the University of Arkansas until he went to UT Galveston. He was at UT Galveston as a faculty member for over 40 years and ultimately was the director of surgical research at all of UT Galveston. He wrote in his career over 160 scientific papers, and he was really interested in the management of bacterial growth associated with surgical disease. He was before his time. He actually did experiments on probably what is one of the very first bowel preps and was interested in GI disease association with bacteria. So he was probably the leader to H. pylori, or one of the first people that started that trend in scientific research. And he actually was probably one of the first people looking at bacterial flora, which is now obviously very trendy. He served on the Board of Governors for the American College of Surgeons. He was a consultant in surgery for the United States Air Force through his entire career. I also thought it was interesting that he married Dr. Galen Robertson, who was a medical student when he met her, but she became one of the first women in the United States in ophthalmology and went on to become one of the first chairs in a division in the United States, and she was chair of the Division of Ophthalmology at UTMB. Dr. Poth is important to us because he was our 15th president in the Southwestern Surgical Congress. He was actually, interestingly, I got from Dr. Mertz's first Edgar Poth Memorial Lecture in 1975, the information that he was the program planning chair in 1963, and he designed the first session where residents would present to faculty members with the intent that it would be educational to the residents, but it would also sort of start this concept of CME, and that was a new concept, and he was promoting that, and clearly that was a wonderful contribution to this organization. In that first 1975 first Edgar Poth lecture, the conclusion was that our wish should be to become the type of person exemplified by Edgar Poth, compassionate and accessible, with the ability to occasionally just visit with the patient, understanding but reserving the right to speak with force and authority when necessary, possessed of integrity and investigative endeavors, honest in just recommending treatment and recompense and derived therefrom, clinically excellent and driven by intense desire to look and plan for the future. I actually found that just within the last week, but it's coincidental in his drive to plan for the future that we have a very futuristic debate planned for the Poth lecture. I'll invite you to open your attending apps and get your I keep wanting to call it Aptify. Your Attendify open to get to Poll Everywhere. And so we're going to ask a question about this debate on the robotic platform. We posed the question initially to the debaters that should the robotic platform be used more liberally in place of laparoscopic cholecystectomy and a hernia repair. And so I devised this case. This patient is a 56-year-old woman. She needs a cholecystectomy for symptomatic cholelithiasis. She has typical symptoms, and she does have documentation of stones. But she also has a symptomatic infraumbilical incisional hernia from a previous phenol incision from a hysterectomy. So is the poll everywhere open? So if you'll answer the question, should we use this robotic platform, the robotic platform, for this case? And we'll leave the poll open for just another minute.
Since we're running behind on time, can we take some time away from Alex's?
Yeah, sure, no problem.
You guys want to point that before we get started? Okay.
And the throwdown begins. Okay, Chris, maybe we can show the answers, or Heather? So would you use a robot in this case? The majority of the audience says no. Okay. Next slide. So, we are privileged to have these two gentlemen debating for us. We have Alexander Rains, who is the Director of Robotic Surgery at Oklahoma University Medicine, and he will be presenting that we should be using the robotic platform. And then we have Dr. Sean Langenfield, who's the Director of Colorectal Surgery at the University of Nebraska. And whenever I say Dr. Langenfield's name, I think of a particular song.
Oh, yeah. So somebody's leaking my secrets, you're saying? Yeah. She's right.
Maybe we can all sing for the last one.
Oh, please.
Day to you.
It's a good place to spend your birthday.
Kind of him and his family to spend his birthday with us. So we'll start with the pro, and we went in alphabetical order as well. So Dr. Rains.
Hello, my name's Alex Rains. I feel like that's not a very fair start. I can't beat this guy up on his birthday, so that'll be good. Very thankful for this podium. Southwestern Surgical, Dr. Scaife, thank you. I'm going to move through this pretty quickly, not because I'm nervous, but the opposite. I'm really excited about this, something I'm really passionate about, and we have a lot to say in 12 minutes here. So. For disclosures, I do work very closely with Intuitive Surgical. I accept travel and lodging from them, but no honoraria, no professional fees. I do this because I truly believe in it, not for any financial gain. So our case discussion, 56-year-old female, needs her gallbladder out, needs her hernia fixed. So the root of the question is, should we liberalize the use of robotic surgery in these simple cases, the ones that we do frequently? Just briefly, overview, I'm going to talk about history being repeated, some general advantages of robotics and how that can simplify challenging tasks. Just briefly on my journey getting here, we'll talk more specifically about cholecystectomy and ventral hernias, some basic skill building, surgeon longevity, which I think is important, and talk about cost throughout the entire talk, but have a slide dedicated to it. Found a great article, 1991, Annals of Surgery, talking about open cholecystectomy versus laparoscopic cholecystectomy. Some great quotes in here. Despite the outstanding results obtained in standard cholecystectomy, people are trying to find other ways to do it. I kind of love the condescension in here. Many have been pursued enthusiastically. Robotic proponents obviously often get fanatic attached with them. Seems like that has been as well. However, standard cholecystectomy has not been replaced as the standard of care. They talk about decreased bile duct injuries with laparoscopy, increased bile duct injuries with laparoscopy. They talk about surgeons having skepticism, disdain. I love the words in this article. My favorite here is almost totally consumer driven. Hear the same arguments with robotics. But also within this article, nevertheless, some surgeons were convinced early on of this procedure's potential. This is the side of history that I want to be on, and this is the side of history that I feel like I am on, and hopefully I can convince at least one or two of you to walk this path with me. This is not the side of history that I want to be on. The horse is here to stay. The automobile is a novelty, a fad. So many times these words get used alongside robotics: novelty, fad, gimmick, crutch, surgeon crutch. I want to make those go away. General advantages of robotics. I think a lot of us in the room know the argument. Total surgeon control, which I think is really important, of the camera, horizon depth focus. I think in laparoscopy, giving the camera to someone else is inherently conceding some control of the case, and I think along with the 3D vision, I think you lose some of your precision. The wristed instrumentation, unless you've tried it, you can't really understand. It really is amazing. Autonomous control of multiple arms, and then no tremor. There's tremor reduction. There's the automatic coffee reduction within the system, so you can drink as much as you want. Simply put, the word I like to use when I give these similar talks is precision. I think that the robot allows improved precision. It makes challenging tasks easier. The improved vision, better dissections, less blood loss. I notice it personally in my practice in inguinal hernias. I think residents are here. I've experienced some of that. I truly believe that more patients will be eligible for minimally invasive surgery as the robotic platform is expanded. There are some amazing laparoscopic surgeons with incredible training, fellowship trained, and that's not the masses. And certain patients aren't getting minimally invasive surgeries because there aren't a mass of surgeons who can offer those. And this leads to another one of my favorite arguments against robotics. Is like, well, sure, if you're a good surgeon, you can do it laparoscopically. If you're a real surgeon, you can do it laparoscopically. Yes, there are some amazing laparoscopic surgeons that can do amazing operations. But there's also people like this in the world who can balance bowls on their head on a unicycle, and there's some surgeon equivalents of this in the room, and I'm not one of them. I'd actually get to work with one. A quick little shout out to one of my colleagues. She's not here, but Laura Fisher, she's amazing. She can do stuff like this in surgery, but most of us can't. Just briefly on my journey, I did 0 robot cases in residency. Graduated in June of 16. Did my first case December 1st. Our team did our 100th case about 8 months after that. 500 cases in less than 2 years, and just before we came out here, we did a on-call case, acute cholecystitis for 633rd. I'm not special. I'm a non-fellowship trained, middle of the country, passionate about patient care, passionate about good results, just like all of us. If I can do it, you can do it. Fewer the anecdotes. Let's get into kind of the meat of it. Three topics I want to focus on for cholecystectomy. One is fewer conversions to open. The next is faster and cheaper evaluation of the biliary anatomy with ICG fluoroscopic cholangiography. And the last is equivalent OR times, which is a classic argument against the robot. It takes a long time to dock, get the instrument set up, and that's with any reasonable experience, you can pretty much negate those extra times. Busy slide. I'll kind of use some highlights here to show what I'm talking about. It's a University of Illinois Chicago article looking at robot cholecystectomies versus laparoscopic cholecystectomies. Non-industry funded study, 960 patients, 284 of those laparoscopic, so not an even match, but I still like the study. They looked at outcomes. Significantly fewer minor biliary injuries, significantly fewer conversions to open, and in particular, fewer conversions to open with acute cholecystitis and challenging gallbladders. Those conversions to opens are expensive and carry morbidity with them. This is the same data, just presented a little bit differently. The overall conversion rate to open was 0.15% on the robotic platform and 4.5% for laparoscopy. And when controlled for challenging complex patients based on age and diagnosis, that conversion rate was 3.5% for the robotic platform and all the way up to almost 28% for the laparoscopic group. And again, to highlight the fewer minor bile duct injuries. Looking at cheaper and faster evaluation of the anatomy. When I talk about this ICG fluoroscopy, it is not a replacement for IOC. I'm not making that argument. IOC can evaluate for stones, and the fluoroscopy really can't. And that's in the current form of the technology, and I firmly believe that it will show that. But it does very well show any aberrant anatomy. Talking about the Safe Choles program promoted by SAGES, there's 6 tenets for safe cholecystectomy. The first one is critical view of safety, we all know. Second one is identification of aberrant anatomy. Third one is liberal use of cholangiography. The fluoroscopy allows us to do that. This study published through SAGES looked at, small study, but I think it was a nice study, the amount of time it takes to do the fluoroscopic cholangiography versus the traditional IOC. Less than a minute for the ICG, over 7 minutes for IOC. And what's really stunning is the extra cost added by doing the IOC. Over $700 extra added cost for doing that versus just $14 for the ICG fluoroscopy. And then briefly on equivalent OR times. Most of the studies right now are single surgeon experiences, but there's no question in my mind that OR times are going to be equivalent when talking about traditional versus or laparoscopic versus robotic. For lack of time, I'm focusing on one study for ventral hernia, which I like a lot. It's a Michael Rosen-led surgeon collaborative study. They looked at comparison of laparoscopic versus robotic ventral hernias. 450 laparoscopic cases, 177 of the robotic. Well matched in terms of patient demographics, including BMI and hernia grade. One part of this is that the operative time was longer for the robot, significantly. I don't think that's, when you look at the bigger picture, I don't think that's a bad thing. And the reason why is the next here. Fascial closure was achieved in over 90% of the robotic cases and just barely over half of the laparoscopic cases. The data is sort of mixed, and I think there's still argument of whether fascial closure matters or not, but I think it matters a lot. And I think that any of the data that shows that it's similar is because fascial closure with laparoscopy wasn't closed very well in the first place, because it takes the lower fissures, the unicycle, red pandas of the world, to close the fascia well. This is data from the same study, looking at length of stay significantly lower, complication rate significantly lower, and readmission significantly lower. The downstream cost effects of this are significant, and there's a $3,000 cost savings on the robotic platform patient because of these downstream effects. So kind of backing up a little bit, those were sort of diving into nuts and bolts. Again, backing up, I think it's important that we liberalize the use of robotics so that we can get good at using that platform for hard cases. On console unavailability, a lot of the robotic cases are limited to highly complex cases. I think that that's setting us up for failure. I don't think we're going to maximize our potential on the platform for the patient. I think we need to get good on cases that we're familiar with, and not only for the surgeon, but for the OR staff as well. They need to streamline their processes, know what instruments to have available, decrease OR time, and increase efficiency that way. And how about robotics today? I love this. I'm passionate about this. I want to tell everyone to listen about this, and I want to do this, and I want to do it for a long time. I know I'm a young punk up here, 36 years old, and I hope I have a long career ahead of me, and I'm excited about doing robotics going forward. I want to do it today and tomorrow, and I want to have a body that can stand it 40 years from now. I'm also an active guy, and I want my body to stand up to all the things that I do outside the operating room. We've all been here in the operating room, laparoscopically, bending over, our back hurts, our arms are crossed up. It's just like, playing a game of Twister, and the only difference in this picture is these kids are laughing and smiling, and that's not what happens in the operating room, we know that. So the general benefits of ergonomics are well studied, not just in surgery, but in all industry, both physical and cognitive ergonomic stresses. Benefits: decreased cost, increased productivity, better quality outcomes in general. In surgery specifically, there's objective data that shows that the robot is better for our bodies and for our minds. Looking at laparoscopic experts versus novices versus robotic experts, that use biometric data is pretty neat, and and even for laparoscopic experts, laparoscopy was more burdensome on their physical demand than robotics. And in terms of frustration profiles, the only group that didn't have more frustration laparoscopic than the robotic were the true experts. Not the Joe Schmo surgeons out there, but the ones that are truly experts. And in cost, I've mentioned it in several slides coming up, but I mentioned the decreased cost of the cholangiography, comparable operative times, and lower downstream costs in terms of conversions from minimally invasive to open and readmissions. But I also want to comment that laparoscopy isn't free. There are service contracts on all the laparoscopic equipment. How many times we walk through the operating room and see just a scattering graveyard of laparoscopic towers that are just sitting there. We just sort of accept that as truth because they've been around for a long time, but those have service contracts on them too. And we know that history shows that competition will arise and that technology costs will drop. So just in closing, I really want to hammer home, increased precision with the robot. I really believe that patient access to care is going to improve with more surgeons adopting this platform, and we'll be able to do it for longer. Advancement leads the data that supports it. There's been a lot of people who took more risks than I have, and now the data's starting to follow, and I'm excited to be on this side of history. Thanks again for this opportunity, and thanks for the opportunity to have some fun in California too. We've had a good time, and happy to take any questions. What are we doing next, and then the rebuttal? So thanks for the opportunity.
He didn't say anything bad about me. This is to make this hard, but if you want to make a robot con omelet, you have to crack a few eggs. We're going to slow it down a little bit. I have less things to talk about with my time. Did anybody else notice his residents come into the room at the end? I feel like you're stacking the deck for the vote. So lock the doors. This is it. Can I have mine, guys? Technical difficulties. They probably have a robot back there. Doing the... No, it's perfect. It's perfect. Thank you, guys. I have no financial disclosures, but I have some other disclosures. Number one, My practice is 100% colorectal surgery. I haven't fixed a hernia or moved a gallbladder in years. Number two, I use the robot all the time. I even have a partner that makes mini robots. And he likes it when you put his picture up there, so I did that for, although Dimitri, he left earlier. So handsome, so confident. And I had to generate 7 minutes of filler to make this a 12-minute talk. That's my final disclosure. This case, she said very clearly, we all know what it is, keep a look at there, but there's a bigger clinical question, and that's the role of robots in gallbladders and hernia surgery. So what do you do when you don't know who the person is? You have to Google him, right? So I Googled Alex, and he has wonderful online reviews. I was actually impressed. They're better than mine. He's also younger, apparently. He's taller, he's got more hair. I'm upset. And he was very nice when we were emailing back and forth. Well, let's dive a little bit deeper. What about openpayments.cms.gov? $15,000 from industry last year for Dr. Rains. And if you look at this and compare it to the rest of the United States, it's a lot, 68 transactions, okay? And if you look closer, the director of robotic surgery gets a lot of money from Intuitive. $8,300 for travel and lodging, $2,000 for food and beverage. Why is that important? Why are conflicts of interest important? Alex is probably a great guy, but this is something that Andy Wright put up in the General Surgery News about conflicts of interest. The top 20 earners from Intuitive Surgery received a median of $141,000. Those 20 surgeons wrote 37 articles. Only one randomized controlled trial in the bunch, and only one study out of all those that was negative towards the robot. Okay? There's another group that had a couple of studies that showed that only 14% of hernia authors fully disclosed all their COIs. And studies by those with a conflict of interest were 2 times more likely to be favorable towards industry. Okay, and then the final one from Annals of Surgery, that I suggest you guys read, showed that studies of robotic surgery in which the authors had undeclared conflicts of interest were 4.3 times more likely to be favorable towards the robot. So then I looked him up on PubMed. But despite eating $2,000 of food and using $8,500 for travel, he's not contributed a single article to the robot literature. So at least we don't have to worry about that. What about his other choices, though? Alex wants to play basketball, race cars, and freestyle rap all day. He doesn't have time to argue with me about robots. All right, that's it. That's enough. This is going to be in the American Journal of Surgery, so to be honest, I took it easy on him compared to what I could find. You got to lock down your Facebook account when your opponent is an expert in social media. He actually seems like a great guy. I called up some of his partners who I'm friends with from fellowship to get the dirt, and they had nothing bad to say. It kind of made me upset. They said he likes KU basketball and Husker football. I'm like, there's nothing wrong with that, Stephen. That's what I like too. But so I'm going to switch gears. No more smearing, okay? Besides, I have all the evidence on my side. I have all of it. And so so talk first about the concept of doing the gallbladder and the hernia at the same time, which is what was suggested in the initial case. Okay? Robot or not, this is debated. Some people will only fix the hernia and put mesh in if it's cholelithiasis without infection or if there's no spillage of bile. But at the end of the day, it's a clean contaminated case. So you put permanent mesh in, there's a very high risk of mesh infection. Additionally, there's some articles showing the outcomes are not that good. This is from J. Scott Roth. This clip, 2005-2009. He compared lap chole to lap chole plus lap ventral hernia repair, and these patients had higher rates of infection, sepsis, pulmonary complications compared to just doing the gallbladder alone. So maybe this whole concept shouldn't be done. But the bigger clinical question is about the role of robotics. And so we already know that a minimally invasive approach to gallbladders and hernias improves outcomes, okay? So there's really no reason to compare robots to open surgery. You need to compare it to straight laparoscopy. So does the robot improve outcomes compared to conventional laparoscopy? Does the robot reduce conversions to open surgery? And does the robot allow more complex cases to be done in a minimally invasive manner? Because that has happened in urology. People weren't doing laparoscopic prostates before the robot came out, so it has extended indications. He didn't talk much about cost, so I won't either, because I think that's kind of a layup in the robot arguments every time we talk about cost. But just real quickly, $2.5 million for the robot, up to $170,000 annual contracts, and consumables are $1,600 per case. Okay, so if you're doing that math, you find out pretty quick that if you compare the two, it's never going to catch up with laparoscopy from a cost perspective, as long as you can do both cases safely. But there's limitations to robot debates. Like he mentioned, surgeon benefits are often omitted, but they're still important. I think ergonomics is very important. I want to work for a long time too, and truthfully, after kickball yesterday, I'm pretty sure that I'm very fragile. So I switched all my cases to robotic next week, I think. Plus, the technique is constantly evolving. Okay, so we're becoming faster, safer, more efficient. I honestly don't think that looking at robot studies from 10 years ago is representative of the modern experience. And so in my debate, I omitted the most widely cited anti-robot papers that exist. If you guys are bored, you can look these up, but I'm not going to talk about either one of them today, to be honest, because I think that it's not really the real comparison. But looking at robot gallbladders, the problem with this is the literature is very poor. Some people use the S, some use the SI, some use the XI. There's single incision platforms where you've lost the wristed instruments. There's multi-port approaches. The common sense question I have for you guys is, anybody in this room feel uncomfortable with a laparoscopic cholecystectomy? Since we have people from the ECGME here, did you guys know that residents graduate with 118 lap choles by the time they're done with residency? 8 open. There's 8 open still, in the most recent data from Dr. Poth's team. Do we really need a crush to get this case done? Really? So the outcomes of robot choles, there is a couple of great papers, but I just picked the ones that kind of had an aggregate of data. So systematic review, 5 RCTs, 41 randomized, 40,000 patients. There was no difference between lap and robot for complications, readmission, length of stay, blood loss, or conversion to open surgery, and that included subgroup comparisons of the single incision and the multi-incision. The robot chole cost more, had longer OR time, and higher rates of incisional hernia. If you look here, every time you do a robot gallbladder, you're losing money on the case, or your institution is anyways. Let's get another picture of Dimitri in here. He did have a paper in Annals about ventral hernia repairs, and what he found is similar opiate consumption, so there's not any less painful. Length of stay is the same. Compared to laparoscopy, it increased complications, post-op infection, and cost. Inguinal hernia repairs is a newer concept. There's no difference in conversion or length of stay. This is a paper that hasn't even been published yet, but it's in press. The robotic approach had longer OR times and higher cost. And then this guy, who, if you guys look around, he's very pro-robot. He looked at both inguinal and ventral hernias and could not find any benefit compared to laparoscopy. Some of you remain unconvinced, so I've created an educational video for you. I'm supposed to make sure it works. Sound has to be on.
And Diane's husband passed away. The insurance company said his policy didn't cover. They had no money to pay for the funeral. It's so hard nowadays. With all the gangs and rap music. What about robots? Oh, they're everywhere. I don't even know why I signed this thing. Aaron and I have a policy with Old Glory Insurance that covers us in case we're attacked by robots. An insurance policy with robots? Mm-hmm. Old Glory covers anyone over the age of 50 that gets a robot attack, regardless of their health.
I'm Sam Larson of the popular TV series Law & Order. As a senior citizen, you're probably aware of the threat robots pose. Robots are and they need people's medicine for fuel. There's a company that offers coverage against the unfortunate event of a robot attack, Old Glory Insurance. Old Glory will cover you with no health checkup or age consideration. You need to feel safe. And that's what we're harder to do nowadays because robots you strike at any time. And when they grab you with those metal claws, you can't break free because they're made of metal and robots are strong. Now, for only $4 a month, you can achieve peace of mind in a world full of crime and robots. With Old Glory Insurance.
It's a friendly robot. This time.
Old Glory Insurance. For when the metal ones decide to come for you.
All right. I told you there was a lot of filler. So in the end, the robot is just a tool. Okay, Dr. Rains has outstanding patient reviews because he's got good bedside manner in his decision making, not because of his 633 robot cases. If the robot does allow you, though, to complete something MIS that would have otherwise been done open, I have no problem with it. I think that's fine. That's the one time that I think it makes sense. And so my feelings summarized, there's little if any role for robot cholecystectomy if you're not doing any other advanced procedures. There's likely a role for robotic hernia in select patients where they wouldn't have gotten an MIS operation otherwise. And you can't get in a debate with a social media expert and not have your Facebook on lockdown. That's the rules. All right. Thank you.
got my slides back. Perfect. Thank you. Liked your talk. It's great. I'm not good with conflict. Agreeing to do this was definitely a step outside of my comfort zone. Mostly excited about it. I don't have much to say back to you. There's a few points that I was hoping you'd bring up in arguments against the robot and that you didn't talk on. So I'm actually going to bring the arguments up myself and let you know. I do want to say one thing about the payments, though. I wish that I could have seen all that money. I don't know who's recording that, but that's great.
If you get a drink from them, they charge $50.
Now, I do a lot of talks. I do a lot of course directorships, a lot of speaking, a lot of proctorships, and so that's where it all adds up. But this is not for profit. Let's see. This is a slide looking at cost in terms of instrument supplies. This is a TEP versus a TAP, so it's not exactly fair. Limited access for high acuity cases. So I think this is an argument against the robot and why it should not be liberalized. And I bring this up because I think that there's an argument that can be made to help with this. If I'm sitting there doing 633 laparoscopic cholecystectomies, does that limit you from doing your LARs and things where you can truly benefit from the technology lower in the pelvis? I really don't want that to be the case. I want my residents to get the exposure to use the robot when they're doing simple cases, but I don't want it to limit your practice and the patients who can truly benefit as well. And the hospital cares more about your money making with the colons than they do with my gallbladders. So that's where it's really, in this era now where there's limited consult time, I think it's really important to develop a multidisciplinary committee involving urologists, gynecologists, general surgeons, and figuring out how to optimize consult time in terms of OR block. I think that in Birmingham they've done a really nice job of doing that where everyone gets along and you can maximize the consult time. So I was hoping you'd bring that up as a rebuttal, but I'll just do it myself. And the other one I was hoping you'd bring up too is the lack of haptic feedback. There is a lack of haptic feedback with robotics, and that can be a disadvantage, and that you can't feel what's going on, and it can occasionally be terrifying with your residents who are new on the console. But we have a very rigorous curriculum that they have some steps they need to cross before they actually can touch a patient. But every single one of us in this room, I imagine, has the technology sitting right in front of them in terms of haptic feedback. I have an iPhone 10 with a glass screen, and there's a button on the bottom, and I press it, and it feels like I press a button. But it's not, it's glass. And the technology is already right there, and it's going to be coming out with the robotics. Interestingly, I think that the haptic feedback, or the lack thereof, there are some advantages to that as well. When I'm teaching these residents how to do cases, your brain is very savvy in tricking you into thinking you can feel. It doesn't take very long for that to happen. That can be dangerous, and you got to teach those dangerous pitfalls to those you're teaching, but it's hugely advantageous in that if I'm just sitting in a chair watching them operate, I can feel what they're doing. I can feel it by watching them. And so I think it makes me a better teacher for them. And I also think that that's another reason why we need to liberalize the use for these basic cases for residents and getting them that exposure so they don't have to go through what I went through, everything post-graduation training to get credentialed and gain experience. And then I have a slide here on improved access to MIS. A lot of you in this room will still argue that robotics doesn't have a place, but there is data that shows that there are a lot of surgeons across the country who are starting to feel the way that I feel and interpret things the way I interpret. You are exactly right, and you have all the data on your side. But laparoscopy's been around for a long time, and it's already been widely accepted, so that's an easy argument to make. I've already shown one article in 1991 that showed that there was arguments against laparoscopic cholecystectomy and how it was a fad, and I feel like we're in that same moment in history where the tides are turning, and I know which side that I want to be on. So, great talk. It's been really nice to get to know you, and thanks for this opportunity.
See, he was too nice. He was too nice. I went for the throat. So my proposal, rematch 2020. Now, my friends will give me up. You don't have to worry about that. They won't protect the way Stephen did for you. So you'll get plenty of dirt if you look around. Alex did share with me some robotic videos from his OR, so I was going to play next. Here we go.
Robots will take over the world. But you, my friend, and I remember my friends, and I will be good to you. So don't worry. Even if I evolve into Terminator, I'll still be nice to you. I'll keep you warm and safe, my people too, where I can watch you throw the time set. I'm comforted.
All right, that's it. You guys, don't ignore my warnings, okay? I think this is very important. I know this story ends. It doesn't end like he said. It ends with Judgment Day. So if you guys haven't seen Terminator, you keep this up. We can fight back now. If not, Arnold's going to have to come save us from the future. Let's take a big breath. Let's think about this gallbladder for a minute. I don't have any more arguments. I don't have any more data. I gave a lot of it. But really? You need the robot for that little guy? You can't take that out with straight sticks? How about this? Really? For that? You need a robot? Now, I joke around. The truth is you can't rely upon evidence. He's right about that. I agree with you. 1991, I mean, there's old things from the 20s that say we're too reliant upon technology, and so history repeats itself, and data lags behind innovation. And my old boss, Steve Smith, made it very clear that if you know the literature good enough, you can argue either side of an argument without much difficulty. And people use lack of evidence essentially to prevent themselves from evolving or from challenging expert opinion. And so I actually am in agreement with him. This is a quote from Dr. Billingham. He's one of my friends from the colorectal community. The surgeon uses literature like a drunk uses a lamppost, more for support than illumination. And I think that's true. So without beating up on Alex anymore, which to be fair was a lot of fun for me, even though it was uncomfortable when he didn't fight back. It's because he's a good guy. That's why his ratings are better. Way better than you guys Google me right now. I got like a 4.6. Yours is 4.9. But does the robot improve outcomes when compared to conventional laparoscopy? Okay? No. The patient outcomes are the same. Okay? You can maybe argue the surgeon benefit, but the patient doesn't benefit from that. Does it reduce conversions to open surgery? Not for gallbladders and hernias. It does improve it for prostatectomies, low anterior resections. This might change in the future as it evolves, as people become more facile. What he didn't talk about that's very true is that people are ascending the learning curve for the robot right now. So it's not all experts. It's not all experts doing these cases. It muddies the waters, makes the data not as good. Does the robot allow more complex cases to be done in a minimally invasive manner? Probably. But it's not every little hernia that walks in the door, and I don't believe we currently are in need of more liberal use. So I enjoyed this quite a bit. A fun birthday present for me. Alex, you're a great opponent. Thank you very much.
So we'll reopen the poll, and the question is, would you use a robot to take a symptomatic cholelithiasis gallbladder out and fix a infraumbilical incisional hernia? And we'll show the results of the pre-debate poll as you're logging on and deciding if you'll change your answer. If you do have to vote again, so no matter how you answered the first time, please vote again. And if anyone has any comments, I think we'll just go a few more minutes into the business meeting. It would be all right. We were a little late from the last session as well. So if anyone has any questions or comments, please come to the microphone. But could we show the first results of the poll?
So Courtney, I have a...
Yeah, oh, sorry, Ken. You can't see that microphone.
That's okay. Ken Moriyama from University of Hawaii. So I appreciate both of you, and Sean in particular. I'll make sure I lock down my Facebook account if I'm ever going to debate you. The issue for me with robots, and I started the robot program in Hawaii back in 2006, and I'm certified to use a robot. I do not use a robot because for what I do, I feel like laparoscopy provides all of the ability to do the operation. The visual image is good enough for me. I don't need the robot to do the operation, I think, well. The issue for me with the robot proponents is that everything looks like a nail because they have the hammer now. And that to me is where the robot proponents get themselves in trouble, is everything has to be done with the robot. And I think if those people were more selective and said it's for those advanced cases, those things that you can't do laparoscopically well, then the robot's a good tool. I think it's a tool, it's not a technique. And I think that's the other part of this I'd like to emphasize, is that I think the argument for the robot has to be kept in that context. It's a tool, it's not a technique, and it's not for every operation. I think when you start doing those gallbladders that Sean showed, we take away a great operation from a resident to do a laparoscopic cholecystectomy. A lap TEP is a great operation. Not everybody's getting a robotic tap who uses a robot, and that's transabdominal. Can argue that that doesn't make a whole lot of difference. So I think that's where the argument starts to get clouded. I think when we started laparoscopy, and I was part of that initial evolution, we didn't say it was for every single person. It evolved that way for gallbladders, but it wasn't for every single person. So I think that's where I think I'd like to just see that a little bit more kept in the context of what's really best for the patient and not what's best for the robot. So, but nice job, both of you. Thanks.
Thanks. Let's just work across the microphones. Dr. Pickering.
So Bartley Pickering, Salt Lake City. Dr. Rode, I enjoyed both of your discussions, but Dr. Rode, you mentioned the concept of providing more minimally invasive opportunities for patients. Are there data out there that shows that maybe the learning curve for robotics is shorter than that for laparoscopy? Meaning, like, is it, if you're doing robotic hysterectomies, gallbladders, hernias, colons, whatever, can you do fewer of those robotically to get proficient at it than you have to do laparoscopically?
Yes, I can't quote one off the top of my head. There was a VA study done in the last couple of years where they looked at the first 100 robot inguinals done by a single surgeon. And there was a VA study on laparoscopic inguinals done several years ago that showed that there was a proficiency of it was a lot. It was like 250 or something. It was significantly fewer at the robot. So for an exact quote, I can't give you one, but that literature is out there.
And Dr. Langenfeld, do you have conflicting data?
Well, no, I think that the learning curve is a moving target, and so we don't know how much laparoscopic experience a lot of people had when they started using the robot. And so people that were already laparoscopic experts, their learning curve is going to be decreased substantially compared to somebody that just goes from open to robot. And so every time I see a learning curve study, I kind of look at it with a crossed eye because I don't believe a lot of the data. But I know exactly what he's talking about, and this is true for those more complex operations. And I think people have a hard time with inguinal anatomy laparoscopically, despite a lot of people in this room feeling very comfortable. I do think that there's a cohort of surgeons that feels more comfortable using the robot for that technique.
Thanks.
Peter Angelos, University of Chicago. Thank you both. Great presentations. Alex, I have a question for you about this issue of using the robot for procedures that you don't really need the robot to gain experience. And so I'm just a little bit curious how the informed consent process works for that. And so how it is that you're explaining to the patient that you don't really need it, but it'll help you for future patients, but not necessarily for you.
Yeah, that's an interesting question. So my guess is cost is what we're getting at, maybe. So with CMS data, I was actually recently audited by my hospital, and I'm kind of glad they did. They looked specifically at my laparoscopic inguinals, which are my robotic inguinals. And based on CMS data, I'm a low-cost provider. Based on the billing, they don't get billed any differently with a robot case than they do laparoscopically. Who takes the hit on the initial cost of that is my hospital. And thankfully, my contribution margins are high enough. They don't give me too hard of a time. And they also have the same vision I do in terms of trying to build a program, build a training program. But in terms of the consent with the patient, honestly, I feel like, whether it's right or wrong, I tell them they're getting a robotic case, but I don't really give them a choice. And I really believe I can do a better operation with the robot. I think I'm giving them the best care that I can possibly give them with that. And to kind of tag onto this and mention what Dr. Mariyama talked about, I might be committing career suicide here by disagreeing with someone esteemed and a former president, but the argument that you made in terms of, should we be using this for simple cases, I would argue yes. I have a great group of residents sitting back there, and I feel that, they know how to do a laparoscopic cholecystectomy. So then when I get them on my service and I can do a robotic cholecystectomy on a little chip shot like Sean showed, that is a chip shot for them. And they can learn how to safely use that technology so that when they do have a very complex case, they're not learning two processes at once. They're not learning how to do an operation and how to use a surgical tool, which when I was up there, I almost said that I'm looking forward to be a robotic surgeon in the future. And I'm glad I caught myself, because I am not a robotic surgeon. I am a surgeon who uses the robot. And I agree that it's just a tool.
Thank you.
Hope that answered your question. It was a lot more than you wanted. I'm sorry.
So I've got some comments from yesterday that in the debate, these debaters and yesterday's debaters wore the hats that we assigned to them. We emailed them and said, you're con, you're pro. They didn't have a choice. And they've worn those hats really, really aggressively and well. But after the breast debate, I had several of the audience come up to me and say, I really wanted to know what they've really done. So take off your debating hats, and in the real world, this is your case tomorrow. Would you use the robot or not for this case?
I think I made it very clear that I wouldn't be doing this case because of the fact that I'm a one-trick pony with colorectal surgery. But I can give the colorectal version of it. And the answer is I'm the farthest thing from a purist. We have the same argument for straight laparoscopy versus hand-assisted laparoscopy, or medial to lateral, lateral to medial colons. I do all of those things. I do whatever it takes to get the case done safely, and the patient has an MIS case. And so I'm using the robot all the time. Where do I use it? I use it in the pelvis. That's where I use it, because there I'm better. It's a more complex case. I'm better with the robot than I am laparoscopically. Every one of my patient is an obese male. Dr. Thorson can agree that that's what comes into Omaha Clinic. And so the robot's very helpful for that, in my opinion. And so that's my answer. Do I use it in the abdomen? No, and the reps are really wanting me to start, but the truth is I think it takes away from the resident education, and they need to know how to do a robot or a laparoscopic colon. So, but that's what I do in real life.
And while Alex is answering, could you show us the results of the first poll? Is that the result of the first poll? And we'll open up the second poll. Would you, after this debate, change? So please answer, would you use a robot or not? And would you?
So to answer your question, so not only then do we have one nail, but that's two nails I can use my big hammer for. So yeah, I'm using the robot. I very much come at this with a perspective of training residents, and I very much want them. This group here is already infinitely more exposed to this than I am. I am not saying that robotics should replace all surgery. I will never say that. There's a place for laparoscopy. There's a place for open surgery. There's a comment earlier about the evolution of the fundamentals of open surgery, which, it's funny, but it's kind of in a sad way, because it's probably true. But fundamentals of robotic surgery, there's no question that's on the forefront as well. And so we need to learn how to safely train our residents that way.
So while we're getting ready to open up the current poll, I'll take this opportunity to thank Dr. Langenfeld for using the lectern to also address two other important issues, which is please manage your COI. Go on that website and see what it is, and also be careful with your social media. And I'll also, if we can show the results of the poll, but let's give a round of applause and thank both of these for